Polytrauma. The term is polytrauma means a syndrome of multiple injuries inciting a defined severity which sequential systematic traumatic reaction which may lead to dysfunction or failure of remote organs and vital systems, which had not themselves been directly injured. Fractures are frequently components of polytrauma patterns. They must be considered wounds of bone and soft tissue, giving rise to stress, pain, and hemorrhage. They can be contaminated and cause compartment syndrome with ischemia, reperfusion, injury. Stress and pain are potent stimuli for neurologic, neuroendocrine, neuroimmunological, and metabolic responses. Systemic traumatic reaction produce a whole body inflammation or systemic inflammatory response syndrome, SIRS. Polytrauma must be considered as a systematic surgical disease. Basic emergency medical techniques skills. Perform technically sound cardiopulmonary resuscitation. Maintain an airway. Obtain intravenous access and start lactate therapy. Reduce and spleen fractures. Perform primary survey a patient and report findings to destination center. Act a concept with physician in early treatment decision. Radio telephone contact. Different studies has identified a 78% incidence of significant orthopedic injury in large series of patients with multiple injury, which is nearly equivalent to incidence of head injury, twice that of major thoracic injury, and 4 times for incidence of significant abdominal injury. Immediate management of multiple injury. The management of patient with multiple injury depends upon an organized and disciplined approach. The most spectacular injury is seldom of most dangerous, and the one which goes unseen kills the patient. If the ABCD written below is false, life-threatening condition will be dealt with first, and I diagnosed injuries kept to minimum. The treatment of multiple injured patient admission to hospital include resuscitation, emergency procedures, stabilization, delayed operative procedures, rehabilitation. The management of injuries may base at the ABC system. A. Airway, B. Bleeding, C. Circulation, D. Disability, neurologic assessment. Check the airway. An obstructed airway causes death most rapidly and must be dealt with first. Complete obstruction of the airway is easily recognized, but partial obstruction causes a gradually increasing hypoxia which goes unnoticed until the partial oxygen falls to critical levels and the patient loses consciousness. Airways check the airway. The airway can be obstructed by blood, vomit, broken teeth, or denture, soft tissue swelling around injury to neck or larynx or facial fracture. The first step of resuscitation is to check that the mouth and pharynx are clear. Respiratory failure can also be caused by chest injuries such as pneumothorax or uh, flared chest even if the airway is clear. Pain can also inhibit breathing. The respiratory failure can follow cervical spine fractures above C. Third, because the phrenic nerve is damaged, but this complication is so serious that the patient seldom reach hospital. Chest movement should be checked regularly. Endotracheal intubation or even tracheostomy by be needed to establish an airway. Stop bleeding. Bleeding is best stopped by external pressure with thumb or first over the bleeding point, but tourniquet by the needed to control bleeding from a limb. Whenever a tourniquet is used, the time of application must be recorded carefully and the tourniquet released after proper control of the hemorrhage has been achieved, or once every hour to avoid gangrene. If there is venous bleeding from a limb, leave the bleeding point above the level of heart. They will stop the bleeding and improve blood pressure. Restore blood volume. An intravenous infusion line should be set up as soon as the airway is established and bleeding controlled. And turning a vein is difficult in the deeply shocked or hypervolemic patient because the vessels will have collapsed if the usual veins in the forearm cannot be entered. Try the cephalic of external jangula if they cannot be entered, either cut down onto a vein. The long saphenous vein at the ankle is convenient and is reliably found 3 centimeters above the up of the medial malleolus and 1/3 of the way back from the anterior edge of the tibia. In a well-organized accidents department, there will be enough people to do all these things at once, while the patient's clothes are removed. It is better to cut clothing off rather than pull it over a limb that may be fractured. A skilled resuscitation team can establish an airway, arrest bleeding, remove the patient's clothes, and set up an intravenous line within 5 minutes of the patient's entering the resuscitation unit. Monitoring of complete examination. When these steps have been taken, the resuscitation team is in control of the situation and less immediate problem can be dealt with. The most common reason for ineffective ventilation breathing after successful establishment of an airway are malposition of the endotracheal tube, pneumothorax, and hemothorax. When immediate action is complete, begin charts, grade injury, examine the patient completely, record ECG, set up central venous pressure line, check the patient again, notifying appropriate specialists. Charts set up record of the pulse rate, blood pressure, and neurological signs, including level of consciousness and pupil size as soon as possible. A brief examination follows at the point to determine the level of neurologic function, the patient level of consciousness, papillary response, sensation, and monitor activity in all extremities and rapidly assess endpoints of resuscitation. Stable hemodynamics, no hypoxemia, no hypocapnia, lactate less than 2 millimole per liter, normal coagulation, normothermia, urinary output, more 1 milliliters kilogram hour, no need for vasoactive or inotropic stimulation. Several systems are used to grade the severity of injury and give a score that can be used to assess the prognosis. Calculate the score and record them. Complete the examination. The the entire patient should be inspected for wounds, including the back. If there is any possible on a spinal injury, the patient should be long rolled until radiographs and available to minimize the risk of displacing the fracture. If this through inspection isn't done very early, injuries will be missed. It isn't only embarrassing, but reprehensible to save the life of the patient and find that we cannot walk because of a mal-united finger that needed only a few turns of adhesive stepping to achieve a perfect result. Measure the wound, bruises and laceration should be inspected. Measure the recorded. Look particularly at the abdominal skin, bruising or imprints of clothing mean that there has been a violent blow to the abdomen, and intra-abdominal bleeding should be suspected. Look also for signs of seatbelt bruising. Examine every bone in the body. That doesn't take long. The superficial bones, including the skulls and clavicle, can be felt with the fingers. The ribs and pelvic, spine and long bone stressed. Fingers and toes can be checked by longitudinal pressure and suspicion area examined radiographically. Record ECG. ECG leads should be applied if done already, and the ECG displayed on a monitor. CVP line. If there has been severe blood loss, set up a CVF line. The normal CVF is 4 to 8 centimeters H2O, and his level should be maintained. Some center pulmonary capillary wedge pressure is preferred to monitor the restoration of blood volume. Check the patient again. To be sure that there is no deterioration, check the patient again. Pulmonary constitution causing respiratory failure, the hypotension from intra-abdominal bleeding may first be apparent at the stage. Other specialists. If any injuries need specialist attention, the relevant specialist should be informed. Facial-maxillary surgeon, thoracic surgeon, neurosurgeon, orthopedic surgeon, and plastic surgeon may all be needed, as well as general surgeon for the management of abdominal injuries. Advanced trauma life support courses and advanced trauma life support are now available for those involved in immediate care. The courses teach internationally agreed techniques to a high standard and are very effective. First aid at the scene of the accident. There is a tendency for doctors, but especially medical students, to try to save life at the scene of the accident rather than attend to practical matters. In practice, very few accident victims require urgent medical care, and those that do usually need equipment found only in an ambulance or accident department. If you are the first person at the scene of an accident with nobody to help, take the following steps. Check the patient's airway and clear if it is obstructed. Feel the pulse. If the radial pulse cannot be felt, feel for the carotid. Recover reposition. If the patient is unconscious, place them in the recover position, but take special care of the spine if there is any possibility of spinal injury. Stop oncoming traffic. Stop traffic before it collides with the crushed vehicles or the patient, and send for help from police and ambulance services. Treat the patient. This done, more time can be spent with the patient. Cover exposed bone with the cleanest material available, arrest bleeding, and comfort the patient. Do not be tempted to pull trapped patient out of cars unless they are on fire, or start definitive treatment such as reduce seen reducing fracture. Confirm that the emergency service are on the way, wait for the ambulance, and give a clear account of events to the crew. When the patient is in the ambulance, the first aid task is done, and it is neither necessary nor desirable so to accompany the patient to hospital. Ambulance teams have great experience in dealing with road accidents and know their own equipment and routines well. They don't need help from a stranger, however gifted. Trapped patients. If the road accident victims are trapped in a car, leave them there until the rescue service arrives. Access to the patient will be difficult because the doors of crashed vehicles are usually jammed, and to drag an injured patient with broken limb or a fractured spine through a broken window is unjustified if there is a risk of fire. The rescuers should wear stud gloves to protect their own hands from laceration on broken glass or torn metal. If the engine compartment has been pushed backwards, the patient may have broken legs and be pinned in the car by the steering wheel. The rescue service has the necessary equipment to cut the window pillars and remove the roof of the car to give easy access to the patient. The patient can then be evacuated to a support place behind the back and lifted directly into the ambulance if necessary after intubation and setting up an intravenous line. Medical rescue team. In many rural areas, general practitioners operate accident rescue service to assist the ambulance crew. The general practitioner car will carry a radio telephone of communication kit with the ambulance control, special equipment to intubate the patient or set up an intravenous line before the ambulance arrives, and narcotic or provide analgesia while the patient is removed from the wreck. The major disaster and major incidents. The major disaster is an event which requires as extraordinary mobilization of the emergency service, fire, police, ambulance, and the major incidents is one which stretches is the thought of the accident department and hospital. Not all major disasters are major incidents. Evacuating families after a flood may not generate even one patient, for example. Major incident procedure. All accident departments have contingency plans for handling major incidents and carry out regular practice drills. As with the management of multiple injuries, success depends upon a well-planned and disciplined approach. The precise details of major incident routines vary from area to area, but a typical plan would be as follows. The designated hospital. The first people to know of major incidents are usually the police. It is they who institute the major incident procedure routine. They select of hospital to which the casualties will be sent, known as the designed designated hospital. Although criteria vary from area to area, 15 or more patients likely to require hospital treatment are usually enough to trigger the major incidents procedure. The major incidents procedure can be instituted by concerned members of the public. Notifying the hospital. The hospital is notified and the switchboard operation initiate the routine at the hospital, which involves almost every department. The medical records staff, portraying staff, mortuary techniques, security staff, administrators, and nurses staff all. have specific duties, and medical staff are only one part of the team. Duties individuals. Any member of staff likely to be involved in a major incident will have an action card which lists their duties, and they will refer to this when summoned to take part in major incidents return. Some of duty might be as follows. Medical controller. There is always one doctor is charge of coordinating the medical service, usually the consultant in accident and emergency. The consultant surgeon of consultant physician of all of on call will go to predetermined ward and create a certain number of beds, perhaps 20, to cope with anticipated number of victims by discharging of transferring patient well enough to be moved. The director of accident service of senior orthopedic surgeon take charge of the accidents department and allocate staff to other areas, but until then the senior doctor present take charge. To avoid confusion of the conflicting orders, the senior doctor wear a brightly colored tabard or sometimes a colored hat for identification. Theater staff. All on-call nurse and operation department assistants go to the operating theater and await instruction. Medical records department. All casualties are issued with an emergency record number and a set of case notes. Special set of records are kept available with bracelets identify bracelets to attention to the injured patient. In some areas, the recording of injured patient is undertaken by the police. Medical staff. All available medical staff should go directly to the accident service and place themselves under the direct to the senior doctor. They will usually be given an action card appropriate to their grade. Medical students. There is seldom any shortage of medical staff during a major incident, and of untrained individuals, such as medical students, can be a real handicap. By all means, ask if there is anything that can be done, but be prepared to do something mundane, such as acting as a runner, carrying samples for the laboratory, or helping to move patients. Organization at hospital. When patients arrive, they are assessed by medical staff and placed in one of three categories: those uh, requiring immediate and emergency treatment, those with minor injuries or none at all, those with serious but non-urgent injuries who do not fit into either of the other categories. This classification of patient is known as triage and was devised by French military surgeon during the Napoleonic Wars. Although ancient, it is still the best way of handling large numbers of cows still. It is best done by senior surgeon. Organization at the scene of incident. Incident control officers. Event at the scene of the incident are under the direction of the incident control office. Usually the senior police office present or the senior fire office if the incident is fire. Each service, fire, police and ambulance, also has its own ICO at the scene. Incident medical office. The incident ICO will request the presence of an incident medical office whenever there are casualties, an incident and emergency uh, um, consultant from another hospital or a general practitioner from the accident rescue service. If one is available, a common choice for such task because they are not needed at the designed hospital. The IMO takes charge of assessing patient, preparing them from transfer to hospital and any treatment that may be required at the scene. The IMO isn't responsible for the organization of rescue service, which remains with the ICO. Of some circumstances of the IMO will ask for the mobile surgical team to be sent of the scene of the incident. The mobile surgical team includes nurses and other staff of take with them equipment kept ready in the accident department of such as a request. First and second line hospital. It is unusual for there to be so many accident victims that the designated hospital cannot cope, but major accident routines include provision for these with a second line or backup hospital nominated is if for then a certain number of patients, usually 30, is anticipated. No patients are sent to the second line hospital until the full quota has gone the assigned hospital. Thereafter, all patients go to the second line hospital and, if necessary, a third line hospital when that is full. Patients sent to the second line hospital are usually more serious injury than those sent to the designated hospital. Surgical treatment. Immediate indication for immediate surgery. Hemorrhagic secondary to liver, splenic, renal, parenchymal injury, laparotomy, aortic, caval or pulmonary vessel tears, thoracotomy, depressed skull fracture or acute subdural hemorrhagic craniotomy, pelvic fracture, stabilization. Prevention of pulmonary failure, femoral staff fracture, pelvic fracture. Pelvic fracture, stabilization, extreme hands-on. Pelvic fracture, stabilization, apparate external fixation. Algorithm for initial assessment, life support, and day 1 surgery. Early fracture fixation in polytrauma and advantages of tone of motility and mobility. Within the locomotor system, treat with high priority limb threatening and disabling injuries, long bone fracture, unstable pelvis injuries, highly unstable large joint, and spinal injuries that require at least professional reduction and fixation. Definitive osteosynthesis day 1 surgery is advisable only when all the endpoints of resuscitation have been accomplished. The general aims and scopes for fracture management are therefore control hemorrhage, control of source of contamination, remove of dead tissue, prevention of ischemia, perfusion injury pain relief, facilitation of intensive care. These concepts can be released by hemostasis, debridement, fasciotomy, fracture fixation, tension-free wound coverage. The management of trauma involves treating extensive skin loss and lesion with the plastic surgeon is important to make the best use of available skin. Trauma has always felt much of the surgeon times. Fracture fixation. Today, multiple injuries, particularly road trauma, keep many beds full and form a large part of orthopedics practice, sometimes to the exclusion of elective orthopedics surgery. Simple fracture types is young patient with a narrow medullary canal are more prone to pulmonary embolization. External fixation minimize additional surgical trauma. Treatment. Floating fragments are difficult to stabilize without external fixation. Crystalloid solution and whole blood. Resuscitation with crystalloid solution and whole blood in sufficient in most stable pelvis fractures. Stable pelvic fracture don't involve a significant disruption of the posterior pelvic ring. The initial displacement of the bone fragment is less. The addition of external fixation usually does little to control pelvic volume or enhance stability. Many unstable pelvic fracture can be managed by fluid resuscitation in the initial phase.